What I'm going to talk about today is how we use quality improvement to reduce stigma and discrimination in healthcare settings. And I hope this is an illustration of how equity and co-production are important principles related to stigma reduction that can help us achieve better health systems. I want to start by shouting out to Thailand. I think Thailand has been a leader in fighting discrimination and creating stigma-free health services. And this is a picture of a province that brought everybody together to focus on stigma reduction in healthcare settings. Thailand also is one of the few countries that has a national stigma reduction plan and actually includes quality improvement as part of that plan, as you see outlined in the slide here. So I'm going to talk to you about what we do and why we do it, to share some examples from national and subnational quality improvement stigma reduction activities, talk about some facility level activities, and then reflect on how we can make stigma reduction a core element of hospital quality improvement programs. First of all, I think we know that equity is an important element of quality, and that equity is defined as providing care that does not vary in quality because of personal characteristics such as gender, ethnicity, geographic location, socioeconomic status, and medical condition. From the Lancet Commission on High Quality Health Systems, which included a comprehensive review of global data, it made very clear that quality of care is worst for vulnerable groups, including those who are poor, less educated, adolescents, and those with stigmatized conditions, the people who are at the margins of the health system. And I think this really underscores the importance for those of us focusing on quality to make health systems that are available and of good quality for everyone. So stigma, we know, deters people from seeking care. It has been cited as a root cause of poor engagement for over 20 years among people with HIV and is a common reason for poor viral load suppression. And typically, to address stigma, people resort to individualized solutions such as training or psychology-oriented solutions like counseling, but don't think about stigma as part of the larger health system that can be addressed through practices, policies, and behaviors. And it is important because we know we can prevent stigma and discrimination by addressing it in this way. Stigma is a social process, and it requires systemic action. The drivers of stigma are common, but their manifestations are often contextual, and so we have to adapt our interventions to each facility or each organization. And the process of scale-up and sustainability are inherently dynamic, and we need a structured way, as we have in the field of quality improvement, to learn as we go. We know that hospitals already support quality improvement, and we want to harness that existing capacity to address stigma, which becomes a new capacity. And we want to remember that in this process, we promote partnerships, co-production, so that we bring together the communities who are affected together with providers and governments. Looking at principles and frameworks for stigma, we know stigma is complex. It involves much more than just the health system, but that's going to be the focus of the work that we do, and you'll see that underscored in this particular framework as we look at organizational issues and stigma. This diagram is specifically related to HIV, and my colleague Laura Nibley developed this, and she identified 4 immediately actionable drivers: fear of transmission, awareness of stigma, attitudes, and the institutional environment that can produce experienced stigma, anticipated stigma, and reinforce self-stigma. And that, of course, then leads to poor clinical outcomes across the whole dimension of prevention, care, and treatment for people with HIV. There has been a call globally to focus not just on the epidemiological outcomes, but also health-related quality of life. And this becomes the fourth 90 or 95 in our epidemiologic goals. We know that people with HIV live long, healthy lives now. They have normal lifespans like everybody else, and so it's not just about getting virally suppressed, but it's about living a high-quality life. We also like to think about the balance of technical quality, effectiveness and safety, and experiential quality, which relates to equitable care and people-centered care. We do this in our work through a balance of the harmony of the yin-yang of quality improvement and performance measurement, which rests on an organizational or structural platform to support those activities. So the network that I'm going to describe to you was funded by the United States PEPFAR, President's Emergency Plan for AIDS Relief, and was given to us to focus on countries to help them support a model that we had initiated in New York State. And so 4 countries came together, subsequently joined by 2 more. So Thailand, Vietnam, Laos, Cambodia, and then later Malaysia and Philippines to form this network. And we support the network itself, the cross-country communication, and the countries then need to go back and stimulate the quality improvement work in the facilities. And they do this without any additional funding from us. Some of them have to figure out how to leverage other funding to do this. And then the healthcare facilities apply the quality improvement principles to reduce stigma. So, when we think about stigma in QI, there's not an obvious measure to think about. And so what we do is we bring together different streams of measurement to create a snapshot of stigma. We can look at clinical performance data if we disaggregate it by the populations that are stigmatized. So rather than look at a facility rate, we want to look at the rate among people with HIV, the rate among the LGBT population, the rate among intravenous drug users in the facility. We add healthcare worker surveys that are based on the research of Laura Nyblade, whose framework I showed you before, and patient feedback and health literacy data. And this gives us a more comprehensive picture about what is happening in the facility related to stigma. Our network adapted the survey to create 8 common measures. The original survey has 51. It's a survey that is used here in Thailand as a survey across the country. But again, we took 8 measures in the network, and they focus on questions like whether there has been observed stigmatizing behaviors, whether people are taking unnecessary precautions to touch people and care for people with HIV, whether they're worried about getting HIV, do they think there are adequate supplies and effective policies in their facilities, and do they think women with HIV should be allowed to have babies? We also adopted common patient experience measures, and these are very common in other experience survey programs in other countries, but they include things like, was information explained clearly? Did you experience any discrimination? Was the clinic welcoming and friendly? Were you treated with respect? Were you involved in decision-making? And did your provider spend enough time with you during your visit? And so in this point, I'm going to turn and show you some examples of how this work has been implemented. Briefly, at the national level, I like to cite the example of Malaysia, which brought together their HIV program in the ministry together with their quality program and involved civil society through the Malaysia AIDS Council and created their program to implement it. They did it very quickly, and it has been very successful, scaling up to all the different states in the country. Here in Thailand, in Songkhla province, when the 2 facilities joined the network initially, the leaders at the province said this really should be happening at all of our facilities, and they decided that they would bring everybody together, do training for the whole province, and adopt the same policies that were destigmatizing in the facilities. And so they included things like canceling special codes that identified people with HIV, and also identifying stigma quality improvement champions as part of their HA committees. But I wanted to focus on the facility level since we're here focusing on hospital quality. And like Dr. Ushiro, I'm going to just highlight some specific features from different hospitals as part of their stories. And so this is from Pompisai Hospital. So here we have Pompisai Hospital, and this is an example, again, where they apply the typical methods of root cause analysis and then identify priorities for improvement. And you can see here they identified areas that included, there was open discussion about patients in public, there were separated waiting areas, there was equipment that was documented as being for people with HIV, and unnecessary masking. And so they addressed these issues with certain actions that included participatory training, canceling the special codes, and having routine feedback of the survey data to the clinic. At Hatyai, they applied the work to antenatal and perinatal care, and you can see here that they identified the primary drivers in their driver diagram of fear of transmission and knowledge about the guidelines for preventing perinatal transmission. And then they went ahead and also developed interventions to avoid stigmatizing behaviors, which I won't go into detail, but I think you understand the point, and you can see the improvement in the data in the graphs below.